The first speaker is actually stepping in for Meredith Reagan. It is Professor Richard Gelber, who's a biostatistician from Harvard. Richard, we very much look forward to composite risks and risk stratification.
Thank you very much. I am stepping in for Meredith, who unfortunately can't be here, but it's my pleasure to do so. I received the slides 15 minutes ago, so you'll have to bear with me. The topic is risk stratification according to stage and pathology. These are Meredith's disclosures. They're very similar to mine. Stage and pathology are the foundation of risk stratification. TNM-based staging and pathology for risk stratification is the foundation upon which everything else is built. As a matter of fact, the AJCC staging has undergone notable updates. So I'll talk a little bit about that. I'll talk a little bit about aspects of staging that we can use, and I'll finish with the most meaningful recent progress, which is risk stratification for stage and pathology based on pathological complete response and based on morphologic assessment of tumor-infiltrating lymphocytes. So the AJCC 8th edition considered the TNM anatomical stage, but added ER, PGR, HER2, and grade. They created a new clinical and pathologic prognostic stages for all patients, clinical prognostic stage, and pathological prognostic stage for patients having surgery as initial intervention. And here are some of the pictures that validate this additional component of staging. You have the TNM stage A, B, C, D, E, and F, and you can see in these pictures how adding hormone receptor, HER2, and grade further stratifies risk based on initially TNM and then further components of pathology. I want to call your attention to one aspect of these curves, which is the shape of these curves, where you can see that the highest risk cohorts are those that have the early events, while the lower risk cohorts seeming to have a continual risk over time. There are online tools for risk stratification, and the 8th edition approach was consistent for 2 online tools for post-surgery risk in early breast cancer. The AJCC refers to as meeting quality criteria. The Adjuvant Online, which is under reconstruction, and I'll talk a bit about the PREDICT score, which for ER negative looks at age, T, N grade, and HER2 with adjuvant therapy, and ER positive age, T, N grade, HER2, and adding Ki-67 and mode of detection. For hormone receptor positive endocrine therapy treated, based on ATTACK, Big 198 in postmenopausal patients, and SOFT and TEXT clinical trials, we have the endocrine therapy treated populations. The objectives differed, but both the IHC4 and composite risk index spread the risk of recurrence for hormone receptor positive across a continuum. So it's not just a cut point, it's a continuum of risk from lowest to highest. IHC4 uses ER, PGR, HER2, and Ki-67, postmenopausal no chemotherapy, adding CTS, clinical features, to the IHC4, adds age, T, N grade, and endocrine therapy. The composite risk for postmenopausal patients uses age, T, N grade, LVI, ER, PGR, HER2, and Ki-67. I'll come back to that. Composite risk for premenopausal, age, T, N grade, ER, PGR, and Ki-67 for premenopausal HER2 negative. These have been shown to be clinically meaningful with a wide range of estimated risk as a basis for endocrine therapy decision making. So here we have the IHC4 and the IHC4 plus CTS based on postmenopausal women in the ATTACK study. These are results for 9-year distant recurrence rates, and they vary widely according to risk. The lower curve is the node negative, next one, 1 to 3 nodes, and then you have the 4+ nodes. You have the 9-year distant recurrence risk, and the clinical IHC4 score on the x-axis. The points show the first quartile and the third quartile, which means for the node-negative patients, postmenopausal age group, 14.3% of recurrence is less than 14.3% for 3/4 of the patients. Above that point, 14.3 for 1/4 of the patients. And you can see how the risk increases according to nodal status. The composite risk was used for the Big 198 study in postmenopausal patients and soft and text in premenopausal patients. The composite risk uses age, TN grade, ER, PGR, Ki67, and HER2. And you can see on the vertical axis, 5-year disease-free survival, or 5 years breast cancer-free interval. And you can see on the x-axis, the composite risk score for the median subpopulations. Lowest risk patients do extremely well in these studies, and the increasing risk score shows an increasing risk. You can see it, the rug plot underneath shows the distribution of the risk scores for these two measures. So this is the risk score in the entire study populations, and if we overlay treatments in these randomized trials, you see for Big 198, the tamoxifen alone arm is the lowest, with the letrozole containing arms higher, and the letrozole alone arm takes precedence for the highest risk cohorts based on the composite risk score. For soft and text, we're looking at the highest risk cohort of patients who received chemotherapy, and you can see the exemestane plus OFS is at the top and the tamoxifen alone at the bottom. For the highest risk cohorts, these range from 60% to 75% for the soft and text. There was a request to put this composite risk in an algorithm, and the algorithm is almost complete as I understand, so it should be available within the next 3 to 4 months. What about Ki67 as a risk factor? It's IHC percent stained cells. Despite international working group to harmonize methodology, there is a lack of scoring standardization, and this has limited its clinical utility. AJCC, however, did include the PREDICT and the IHC4 composite risk. They all use Ki67 as part of the estimation of risk because Ki67 is robustly prognostic, as shown in these diagrams from Big 198 and soft and text. But there is a new marker on the block, tumor infiltrating lymphocytes. And the International Immuno-Oncology Biomarker Working Group on Breast Cancer, led by Salgado, Loy, and Denkert, did not want to make the same mistake that was made with Ki67. So they've developed a website, a training algorithm, and standardization for the assessment of stromal stills. Standardized morphologic assessment of tumor infiltrating lymphocytes, emerging as a prognostic marker in early breast cancer. Here is the example from the Big 298 study using chemotherapy, and you can see as has already been presented, especially in the triple-negative breast cancer cohort, the major separation in prognosis with respect to TILs. What about in HER2-positive disease? Potentially prognostic, treated with HER2-targeted therapy and chemotherapy, and these are all studies showing the value of TILs in the neoadjuvant setting for neo-alto and GBG, and in the short hair study. TILs appear to be prognostically significant. This is the triple-negative meta-analysis, prognostic in patients with triple-negative receiving adjuvant chemotherapy, and it adds to the prognostic model with age, TN grade, and chemotherapy. What about PCR after neoadjuvant systemic therapy? Residual cancer burden and PCR prognostic, meaningful risk stratification after neoadjuvant therapy, eligibility for trials focused on escalating therapy in patients with residual disease. So this is a new marker, PCR versus residual cancer burden for developing new therapies and determining risk stratification and trial designs. Residual disease selects high risk for escalation of therapy. Here are two studies you've already seen. Clinical utility of residual disease, meaningful absolute improvement in 3-year disease-free survival from control treatment with escalation of therapy among patients having residual disease, both in the CREATE-X study for triple negative and in the Catherine study for HER2 positive disease. What about S-TILs in residual disease? After neoadjuvant systemic therapy for triple-negative or HER2-positive disease, they may add prognostic information to PCR and RCB. Triple-negative, this is a study that triple-negative breast cancer, 375 patients, class 1, class 2, and class 3. So RCB class 2, clear separation. HER2-positive cohort of 45. In conclusion, stage and pathology are the foundation of risk estimation on which everything else is built. Evidence of prognostic role of morphological assessments of stromal TILs has strengthened, in particular in triple-negative breast cancer. Residual disease after neoadjuvant systemic therapy has demonstrated ability to define high-risk population for escalation of adjuvant therapy, and the role of S-TILs in residual disease may further improve risk stratification. Thank you very much.
Thank you so much, Richard, for taking, and also Shari Gelber, by the way, for taking over the talk. Are there any immediate questions?
Rich, I have an immediate question. Talking about prognosis, can you just mention something about endpoints? Because there was a big mix about different endpoints. For example, you mentioned Predict UK, and Predict UK just assess for 10 years overall survival, whereas other tools assess for very different endpoints like MFS, DFS, 5 years, 10 years, etc. So, the vision you have on the benefit of a treatment is very different if you use overall survival or DFS. I mean, even that is something that might influence your specific decision. So could you just come back to that and say us what endpoint, should we have a single endpoint? Should we use carefully the different endpoints we have in different tools?
It was hard to hear you, but I think you're asking about endpoints for judging risk. And of course, as I stated, it does depend on the time frame, whether you're looking at long-term risk or short-term risk. There is a substantial debate on which endpoints to use, motivated by what regulators will accept. So there's that issue, just to put that on the table. Invasive disease-free survival rather than specific sites of recurrence, whether you should count contralateral breast cancer recurrences. We have that in a study we're running now, where there's a question about contralateral breast cancers being included in the endpoint. But you're right, if you're looking at metastatic events as the key thing that you want to control, then define that in the protocol and don't be bashful about it, and use that as your indication. And see, because I think that is the key feature for most of the treatments that are being evaluated today, especially the systemic therapies, where it's the avoidance, reduction of the risk of a metastatic reoccurrence. Yeah.
I do agree, and while talking to patients, it's so important what you're talking about. I mean, overall survival is something that is very different of a metastasis-free survival for a patient, so I think we should be very careful about that.
Yeah. I mean, what we usually do is have a primary for one purpose and then make sure we look at the secondary type of endpoints as exploratory analyses, because there are the issues of regulatory approval and there are the issues of caring for the patients, and they may not be consistent.
And part of the development has been based on regulatory approval, so we are talking of something that is different, so we should be careful of it. Any other questions? Okay, so thank you very much, Rich, and we will